first thing a disclaimer. I'm rubbish at tech and tend to hit the wrong button, so bear with me. I've got two images. You've heard a lot this morning, and I am not an expert in any of this, and I start to get a bit overwhelmed by how much is possible, but also where we're starting from. So I've got two images. First of all, I want you to picture me with a Kiss Me Quick hat on, because obviously we're in the patch. And the Kiss Me Quick hat is, for me, I want to keep it simple, not least because I'm a bit stupid, but it's also about what can we get on and do now. We don't have to wait for the whizzy stuff to come. And my second image is a hat, but also the stick of rock. So I am one of the directors in the National System Transformation Group, and what we're aiming to do is to support systems to move on in their journey to become really successful integrated care systems. I am a absolute passionate about data-driven quality improvement. So the stick of rock analogy for me is that's running throughout everything I am and everything I'm going to talk about. So with those two images in mind, I'm going to actually let Justin know we have made some definitions nationally to try and move on from it's all things to all men. And what we think, and we've done this with NHS Digital, NHS Improvement, Public Health England, to try and just give a common understanding from all the national partners as to what we think population health management means for systems. We've gone with 5 outcomes which build on the 3 triple aims, and the 5 outcomes add the real importance and the evidence that is coming out now about what workforce experience means for outcomes for patients. Outcomes for local populations, but also we think particularly with population health management and what the system level ability is, the focus on health inequalities has to be really strong in this. We've gone for 2 simple definitions. Population health, essentially improve outcomes, maximise well-being, reduce inequalities, but focus on the wider determinants of health. So really coming back to what Claire was talking about this morning. And population health management is therefore the ability to use data, whatever you've got, to drive decision-making with the evidence that you have, to therefore really focus on what you can do to get that maximum impact for your population. And just coming back to the wider determinants of health, as Claire said, if we only have 20% of our impact by focusing on health, then therefore as a system, what the power you have available to you by working together is to really get upstream with that other 80%, to focus on what does housing mean in terms of health, what does transport mean in terms of health, how can your wider public sector workforce, such as police and fire service, really help you who know lots about their local populations, about your local populations. We've, again, simplified things. There's lots of key things that come under the population health umbrella. We think there are 3 core buckets. There's the infrastructure, the intelligence, and interventions. Neatly 3 I's. We do like to have lots of things we can put it into an acronym in the NHS particularly. Infrastructure is about both organisational and technological. So how do we ensure that we have that senior level commitment to making decisions that are based on data? How do we ensure we've got the right digital platform, the right digital architecture that has to be planned at a system level if the data flows are going to make sense for all the people working in that system? In terms of intelligence, what's the capacity that you have in your system? Where are the capabilities and the skills? Are they sat in individual organisations with lots of people doing the same thing? And how could you lift that up into doing things once where it makes sense? How do you use all the different tools to enable you to really get underneath the skin of what the high-level data tells you and what the questions are for your local populations you want to answer? And in terms of interventions, what are the things that are going to make the difference for those different people in your population? What is it that's going to make the difference in one particular neighbourhood versus the other? What is it that the non-clinical interventions could have much more traction with versus the clinical interventions? Going back to, actually, if we get it to grips with the 80% of the difference we can make here. And I'll come back to the fact that this is not about waiting for perfect. It's not about waiting for all of the things to be in place to do this. We already have data. We have lots of data that we can start to bring together. We know what some of the key priorities are, and we know what we can do about it now, and we can get on with making those changes happen. This is where the technology and me just don't go. Am I pointing in the wrong direction? No? Thank you, Lindsay. Thanks. So just trying to then imagine what does it actually mean at a system level in population health management? And we want to start with the individual. So co-design, co-production of all of the services that make a difference, the individual runs throughout this. But thinking about the specific, what will it mean for a person in your system? And I'm going to use COPD because my dad has COPD. So I'm trying to encourage him to use a bit of an app, that the My COPD app, that actually starts to help him understand where some of his trigger symptoms might start to help him think about when he might need to seek different levels of support. Now that can link to clinicians actually getting some of that data and proactively helping to ring my dad up and say, just notice this, let's make sure we get you sorted for whatever. I'm no expert in COPD either. But that data, if we could plug that into the patient record, starts to give a really powerful source of understanding for my dad who can best support him with what. At a neighbourhood level, understanding where people live, what the housing conditions are, where some of the issues might be around warm homes or damp that we need to support out. We can start to plug that data in, but target those particular areas. People like the fire service going in and doing a home visit, being able to identify some of the problems quite quickly. At a place level, using weather data to start to predict when actually somebody might be at risk of a hospital admission. How can we therefore flow the rapid response teams into supporting people really proactively when things start to deteriorate and get them home really quickly? And at a system level, what does that look like in terms of housing policies? What does that look like at a local council with all the partners around the table making different decisions about how to plan these interventions at those sorts of stages? Oh, thank you. But bringing it back to a practical application, this is all about quality improvement. It's about using a cycle, a learning cycle, to really think about what do you know? What are the questions you want to answer? How can you then start to drill into that with what you've already got? What do you look at in terms of, or what can you spot in terms of the variation and the opportunity analysis quite quickly? And then what are the interventions you can start to put in place for your local population now? And at the different levels they build up to become the big, large-scale change that you're wanting to see happen in Lancashire and South Cumbria. But rather than being overwhelmed by there's so much we can do, starting with something that builds up to the bigger overarching plan using quality improvement is a really powerful way to just get going. Thank you. And again, we've got the triangle. We do like the triangle, as someone said earlier. We think, therefore, that the things that make a difference in terms of understanding some of that data is looking at the segmentation, and that can be quite simple. Is looking at then within those segments who are the people at most risk, and again that rising risk, who are the 18 or 20% of people that are going to go from that middle triangle to that top triangle, and how can we get there quicker? And then within those the different levels of risk, what are the most impactable interventions that will be different for different people within those particular risk levels? That then helps us target and tailor the interventions to make most sense. That's all enriched, though, with much broader social data than we currently have. So this is starting to get us to understand where can we bring in housing, social isolation data, who lives in what sort of accommodation, where are our pockets of key employment or unemployment that are going to all impact on people's health. Plugging in all of that data is the ability then to really get a rich source of where can we, at some point in the near future, start to think about that individual right in front of us at that point of interaction to then look at the intervention that's going to make the most difference for them. Thank you. So on that basis, what we've been trying to look at from a national support offer, and this is where we really want you to tell us what you think you need. We're supporting the 14 integrated care systems. We're supporting them to come together and learn from each other, as well as from the experts internationally and nationally. And what we've tried to do is look at 9 things currently. We have looked at actually what does a national approach look like so that we stop confusing people with PHE says one thing, NHS England says another. Different people coming in at different times doing a bit of it, but not necessarily thinking about the totality of what's needed. We've put in place dedicated sponsor teams to actually come in and support systems with the things they want to do and bringing in the learning from the other systems as they go. We've developed with experts maturity matrix to help systems assess where they are against the 3 capabilities and then plan what the priorities are. How do we break this down into a manageable approach so that this year we see progress, we see improvements, we see change starting to be made based on where you are currently at? We're pulling together all the and signposting what all the evidence tells us about the things that will make the biggest difference. And that learning is evolving on a weekly basis, particularly learning from lots of other countries. We have a community of practice forum that brings together the leads from each of the systems to help try and tackle some of the wicked problems together. What is it we can do once nationally? What is it we need to help people with locally? We've got a flat pack of practical plug and go, what can you just do now? We already know some stuff that works, we know some of the tools that can help you answer whatever questions you've got, and we know some of the interventions that are making the biggest difference. That's pulled together into a wherever you are now, we can get going with this. We can support with external partners where people feel they've got some gaps with the framework that will be launched in August. We're offering to support localised development programme with a really intensive support offer to come into the system to help you go further faster. We're really keen to enable all of the integrated care systems to become national exemplars. We've got some specs coming, so what do different functions look like in terms of best practice? How do you use that for your analytical teams and your analytical abilities in the system? And finally, we've got a dashboard that will nationally enable a consistent view across the system that allows people to benchmark where they're at and where they want to learn from others who may be doing better. And that is it. I'm just going to sum up with, I had to think about how to shoehorn football in somewhere, because otherwise I'm not relevant, am I? So I just want to summarise a few takeaways. 5 aims. We're trying to achieve those 5 outcomes. We've got 2 definitions to try and keep it simple. We've got 3 capabilities to, again, try and keep it simple in terms of those buckets, the 3 I's. We've got 3 different tiers in a system, and population health management is in every single one of those tiers. It is everybody's business. We've got those 9 planks of support, and in hindsight, I should have made those 11. They could have been one of the players on the team. But ultimately, and here's where I go with my football analogy, we're all aiming with this to hit the 1 goal. That's as good as I could get with plugging the football thing. Thanks very much.